Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about keloid. Definition: a keloid represents excessive proliferation of collagen or scar tissue after trauma to the skin. Clinically, a keloid appears as an elevated, firm, protuberant nodule or plaque. Incidence: keloids are relatively common. The incidence is highest in people aged 10 to 30 years. Black people are particularly prone to keloids. In African descent populations, the prevalence is approximately 6%. History: the trauma responsible for inducing the keloid is almost always remembered by the patient. Often the trauma is obvious, such as ear piercing, surgical incision, or other wounds. Keloids develop hours, weeks to months after the trauma. New and actively growing keloids often itch, whereas stable long-standing ones are asymptomatic. Physical examination: a keloid looks like an overgrown scar, which is what it is. It is protuberant and firm and usually conforms roughly to a pattern of the original trauma, although it is more extensive. Keloids are often pink or dark brown and have an irregular border with claw-like extensions. They may occur anywhere, but they are more common on the earlobes, secondary to a piercing, shoulders, upper chest, and back. Differential diagnosis: the difference between a keloid and a hypertrophic scar is mainly quantitative, with a keloid expanding beyond the limits of the original trauma. A dermatofibrosarcoma protuberans is a rare malignant fibrous tumor that clinically may look like a keloid, but the patient usually has no history of trauma, and the lesion continues to enlarge. If malignancy is suspected, a biopsy should be performed. Laboratory and biopsy: the diagnosis can usually be made on clinical grounds. If doubt remains, a biopsy can be performed for confirmation. The histologic examination shows whorls and nodules of highly compacted hyaluronized bands of collagen. Fibroblasts may be increased in number but not markedly so in mature keloids. Mast cells are prominent, and release of their histamine content may be the cause of the often associated pruritus. The overlying epidermis may be atrophic. Keloid: multiple hyperpigmented, smooth, firm, protuberant nodules and plaques are present in dermis. Highly compacted whorls of collagen can be seen. Therapy: surgical removal alone, although tempting, is contraindicated because it is often followed by a recurrence that is larger than the original lesion. Repeated intralesional injections of steroids, for example triamcinolone and Keloid 40 at monthly intervals, may cause keloids to flatten, which is a goal desired by some patients. Keloids can also be injected with a mixture of steroids and 5-fluorouracil and must be injected superficially to avoid ulceration. Light cryotherapy can also be used prior to injections to aid in pain control and softening of the scar tissue. Surgery may be used if it is combined with another modality such as intralesional steroids or low-dose radiotherapy. Pressure dressings are also helpful when applied after surgery or injections. Silicone or elastic gel dressings applied daily for 2 months have been shown to help flatten hypertrophic scars by mechanisms that are unknown. Note: surgical excision should never be used alone in treating keloids. Course and complications: untreated, the usual course of a keloid is that of gradual enlargement to a steady-state size. Keloids are much less likely to regress than hypertrophic scars, but in either case, the time course for regression, if it occurs at all, is measured in years. The major complication is cosmetic disfigurement, which may be profound. Pathogenesis: increased fibroblast activity initiated by tissue injury results in a marked increase in collagen synthesis. Dermal ground substance, primarily the chondroitin 4 sulfate component, is also increased. Investigators have suggested that this change may inhibit collagen degradation. Collagen production may also be affected by imbalance in or altered fibroblastic responsiveness to tissue cytokines. For example, collagen synthesis by fibroblasts is stimulated by transforming growth factors beta and is inhibited by interferon. Clinical case: a 22-year-old man presents with a right firm lesion on his left shoulder that developed after a minor burn injury 8 months ago. He reports that the lesion has continued to grow beyond the borders of the original wound and is sometimes itchy. On examination, there is a thick, rhabdo-hyperpigmented, irregularly shaped nodule extending well past the margins of the initial injury. The lesion is not tender and shows no signs of infection. Which of the following is the most likely diagnosis? A. Hypertrophic scar. B. Keloid scar. C. Dermatofibroma. C. Dermatofibroma. D. Epidermoid cyst. And E. Cutaneous sarcoidosis. According to our explanations, it's obvious that the correct answer is B, or keloid scar. Explanation: keloids develop due to excessive collagen deposition, especially type 3 collagen, and grow beyond the original wound boundaries. It's common on shoulders, chest, earlobes, and upper back. It's more common in younger individuals and people with darker skin phototypes. Lesions are firm, rubberized, and often itchy. Differential diagnosis: hypertrophic scar is erased but remains within the borders of the original wound and may regress over time. Dermatofibroma is a firm pupule, usually on legs, and dimple sign is present. An epidermoid cyst is subcutaneous nodule with central punctum and is filled with keratin. And cutaneous sarcoidosis is a red-brown papules associated with systemic disease, and non-cassating granulomas is present. Okay, this was an explanation about keloid. Thank you for your attention.